Good morning. I'd like to thank the Cervical Spine Research Society, as well as Dr. Sasso and Dr. Vaccaro for inviting me to participate in this panel. These are my disclosures. So traditional fee-for-service is a sinking ship. It's unsustainable. And even though the bundled payments represent a small life raft in a vast open ocean of turbulent seas, I really believe this will provide safety for those of us who've decided to embark on this journey, at least for the time being. As Dr. Vaccaro cleverly labeled this symposium a race to the bottom, I just wanted to use another ship analogy here. CMS, which is the largest purchaser of healthcare in the United States, has decided that bundled payments represent such a significant opportunity for them that they have essentially dropped the coins down to the bottom of the ocean. So for those of you who continue to swim in the CMS ocean, you better learn how to dive for these coins. How does CMS really define value-based healthcare? Well, they talk about better, improved healthcare, et cetera, but they're really talking about cost, not surprisingly. And if you look at the language very carefully, they are trying to redesign healthcare delivery. And as you'll see later in this talk, they have begun the shift earnestly. We've heard negativity before in the spine surgery space. We're hearing it about bundled payments. Spine surgery doesn't work. Well, for those of us who've been at it a while, we've seen vast improvements in technology, diagnostics. We've made huge strides in training our surgeons, and we have superior outcomes than we used to have before. Similarly, bundled payments don't work. We hear a lot of negativity. There's a lot of published papers about that. But regardless of what those papers say, there are enormous market forces bearing down on fee-for-service, and they are changing the shift to bundled payments and value-based healthcare. Data analytics are improving. Standardization in clinical care pathways are gaining acceptance. And there's a new definition of outcome to include not only clinical outcome, but financial outcome as well. So just as an example, a quick hypothetical example of what a 50% risk share in a cervical spine fusion bundle looks like, the money that you would save in an episode if you come in under the target price, hypothetically, let's say you saved $8,000 from the day of surgery to 90 days post-discharge, that's distributed in a net payment reconciliation amount, or NPRA. And let's say that was $6,000 after fees are subtracted. 50% risk goes to the episode initiator or the surgeon, so you're able to pocket 50% of that. Similarly, if you spent more money than you were targeted, you would be responsible for that 50%. In a fee-for-service model, no one person or entity is really tied to the entire episode of care, and an episode being defined as 0 to 90 days post-procedure. In an at-risk or value-based bundle model, the surgeon or the hospital, for example, the entity that is controlling the bundle is financially tied to both managing the clinical care and has a financial upside and downside in terms of the risk. So it's a coupling of the clinical and financial modeling. This is just a quick example. We were in the bundle payment care program, the original one, and this was kind of a training ground for us. This is a slide that shows you the dashboard that we used to get from our episode initiator partner, Episode Solutions. And really what it did, even though this is a busy slide, it allowed us to look at numbers and start to understand what exactly each example of a spend correlates to. So for example, if somebody's going to a skilled nursing facility, which is seen over here at 37% of the time, you can see how much of a negative effect that has on the net payment available after the bundle, versus my patients who very few of them went to any type of post-acute care utilization, and we were able to save tremendous amount on spine fusion bundles in BPCI advanced, or BPCI number 1. So what did that teach us? Well, it taught us that in order to manage care, there are certain things that we had to do. We wanted to educate ourselves about the right place to do these surgeries, inpatient versus outpatient. We began using nurse navigators who helped coordinate the care after discharge. And we began working with selective skilled nursing facilities and home healthcare agencies, basically to get good clinical outcomes, but do a smarter spending downstream. We very rarely used inpatient rehab or skilled nursing facilities. This is a current snapshot of the RP1. These are reconciliation periods. This is the BPCI Advanced program, which is currently underway. And as you can see here, we have been saving money on a reasonably consistent basis in our cervical spine fusion. So the fact that this is not working is simply not borne out by the numbers that we're generating. And as you can see here at a snapshot of the RP3 period, we're saving approximately $3,800 on average in a cervical spine fusion bundle. So the thing to start thinking about as you look at these next few slides, you're trying to redesign the clinical post-discharge care pathway. So by decreasing expensive spend, such as a readmission to a hospital or an inpatient facility utilization, as you decrease these episodes, you're going to possibly get increased utilization in other spending categories, such as home health care or home physical therapy. As you see here, we have decreased our historical SNF utilization over the 2019 to 2020 period. And what this slide tells me is that the fewer patients are going to SNF, but the ones that are going there need to be there. So they're staying slightly longer than they did on a historical basis, but it's better to have a few select patients there who need to be there than everyone there who doesn't need to be there. So we're trying to optimize spending. And this is where you can see, again, walking down from the most expensive being inpatient rehab down to the least expensive being home health care. We're going to get some increased utilization of home health care because some of these patients on a historical basis were in skilled nursing facilities or inpatient rehab. So the home health care utilization has gone up from a percentage utilization basis, but the number of home health care visits on a per episode basis continues to decrease. So this concept of optimization of spending is important. Financial risk is not something that most physicians are comfortable with. We don't have a lot of internal navigation. We don't know how to really actuarially assess these patients. And in the original BPCI program, as well as the BPCI Advanced, this was somewhat easy. We could look at individual bundles and choose the bundles where we thought we could make more money and control the spending. However, CMS has now determined that they are done with that, and they're going to force everyone into an episode service line group. So essentially in January of 2021, if you're in the BPCI Advanced program, you're going to have to take all the bundles within that service line group. So in spine, if you do spine surgery, you can't just cherry pick out and take the cervical fusions and the posterior lumbar fusions. You're going to have to cover them all. And to make things even more competitive, remember that first slide where I was talking about CMS is out to redesign the way they deliver care? 2024, this is CMS officially dropping all the coins on the bottom of the ocean. So everyone who's in CMS in terms of participating in the fee for service in CMS, you will be tied to bundle payment participation one way or another. And as you can see down here, they're going to aggregate people, physicians, into either hospital delivery groups, or if you're going to already partner with somebody in the BPCI program, this is going to be mandatory participation. So let's pause for a minute and understand maybe why this didn't work for the Rothman group. I pulled this off the internet, and all the way back in 2017, this talk was given. Look at, Rothman has a director of payment strategy and a director of quality. This is a highly sophisticated practice that is already demanding that their surgeons perform at a very high level. They're looking at cost. They are saving costs for their early episodes on a very high level, very rapidly. But paradoxically, this works against them. And I think this is why their experience has been negative. They were too good too early. The way CMS works in these bundle payment programs, they look at historical performance that predates you enrolling in the program. And if your data is already extraordinarily good, it's going to be very difficult to improve. So they were basically plagued by being too good too early. And by the time CMS dropped the coins on the ocean floor, they had very little wiggle room with which to improve. So what happens then? Let's say you're a Rothman. Let's say you're the Core Institute, Cleveland Clinic, these facilities that I think there's going to be a bifurcation. The rest of us, the 90% of us who are just dealing with bundles, we have a lot of opportunity to improve and save money and be able to financially benefit from that. But these groups that are very far down the line, they're going to move towards a more capitated population-based management service group. So there are things that go on beyond that, which continue to offer financial opportunity. It's just that these simple bundled payment and risk-based strategies are really going to be for the early beginners. Those who have matured past it will be moving towards population health risk management. So what about the rest of us? Those of us who don't have those internal director of healthcare data inside our practices. The 90% of us out there delivering healthcare. We don't have the infrastructure to do this. We need help. We need advisors. And if you look at some of the comments here, value-based contracts involve complex actuarial calculations. Most of these contracts, when you get into the self-insured as well as the commercial, these will be won and lost at the contracting table. They won't be necessarily won and lost because of what you did on a day-to-day basis in healthcare. So these are going to require significant changes in advisory capacities to our practices. And to that end, a number of businesses have emerged that are doing this, just like we recognize all of the implant manufacturers that we've been using for the past decade or so. These names are going to be much more common, and you're going to see more of them. As I said, Optum, some of these are well down the managed care, value-based healthcare continuum. Optum purchased NaviHealth. NaviHealth was a navigator of SNFs. Hopco, which is a spin-off of the Core Institute, purchased the Stryker Performance Solutions system that had to do with hospitals managing bundled payments for total joint replacements. Fusion 5, Episode Solutions, which is the company that we use in our practice. Signature and Archway Health are other companies that have emerged to help physicians navigate these waters. So switching back to the bundled payment initiative for a moment. What has not worked in BPCI Advance? Well, CMS has changed the target price in midstream, which has been very disruptive and financially negative. And if you look at some of the doctors who are monitoring their patients rather than managing them, a lot of these services, these companies have just helped the doctors monitor it, and the doctors are still free to do whatever they want. They're not saving money and they're losing money. You need to manage these patients. So what we have found is in terms of a key to bundled payment success is really active management. You need to think like populations. Manage to the 80 to 90% of your patients. Manage them the same way. Don't create an individual management strategy for every single patient. Take care of the one-offs, but standardize your delivery of your healthcare post-surgery. Think like insurance companies. You're going to have to be partnered with large groups of other doctors, and you have to control a large number of patients so that you can stratify that risk. And finally, you need to align with experienced business partners who know how to assess these things from a contract basis, a financial and actuarial basis, and have the technology to keep you connected to your patients. One of the most important and most significant changes in my practice has been this real-time management. We communicate with a physician app with our patients through a nurse navigator. We know where our patients are. We know what they're costing in terms of their care, and we know how far down the bundle they are, so we can manage them real-time, but this requires real effort. So in order to do well in bundled payments in a private practice setting, surgeons must be engaged. If you're fully engaged, you can make money. You will also be able to demonstrate a lot of satisfaction. Our patients enjoy having this type of interaction with their apps and the nurse navigators. As I mentioned earlier, you need to manage your patients, not simply monitor them. You need to commit to a post-acute care platform and a pathway for your patients before the surgery and stick to it. If a patient has a complication, you manage that appropriately, but you continue to try to drive your 80 to 90% of your population through the same post-acute care discharge planning for your surgeries on a predictable basis. In conclusion, government policies and very large market players are enacting sweeping changes to move away from fee-for-service toward bundled payment and value-based delivery systems. This represents an opportunity for spine surgeons to control the episode. We can ensure quality of care and still benefit from the savings that we generate. Negotiating contracts will be the most important part of navigating these waters with the commercial and self-insured pools. And it's important that you understand the financial ramifications of these contracts as you manage bundles or population risk. Financial risk is an unusual position for MDs to be placing themselves in. It is uncharted territory and it's complex for most practices. So make sure you understand it and begin partnering with practices or business entities that navigate these waters successfully. Thank you.